MitraClip, more broadly called mitral transcatheter edge-to-edge repair, or mitral TER, is a catheter-based treatment for selected patients with significant mitral regurgitation. The procedure reproduces the surgical edge-to-edge, or Alfieri, concept by joining the anterior and posterior mitral leaflets at the site of regurgitation, creating a more competent valve while avoiding open-heart surgery. Current American and European guidance emphasizes that TER should be used after careful anatomical and clinical selection by a multidisciplinary heart team, ideally in an experienced heart valve center. Mitral regurgitation occurs when the mitral valve does not close effectively during systole, allowing blood to leak backward from the left ventricle into the left atrium. Over time, severe regurgitation can cause dyspnea, pulmonary hypertension, atrial fibrillation, heart failure admissions, ventricular remodeling, and reduced survival. The first step is not choosing a device but defining the mechanism. In primary mitral regurgitation, the valve apparatus itself is abnormal, for example due to degenerative prolapse or a flail leaflet. In secondary mitral regurgitation, the leaflets are often structurally normal, but the left ventricle or left atrium distorts annular geometry and leaflet cooptation. In primary mitral regurgitation, durable surgical repair remains the preferred treatment for operable patients when a good repair is expected. However, patients who are elderly, frail, or at high or prohibitive surgical risk may be candidates for TER if valve anatomy is suitable. In secondary mitral regurgitation, treatment begins with the ventricle and the heart failure syndrome. Guideline-directed medical therapy, including contemporary heart failure therapy, should be optimized first, and cardiac resynchronization therapy should be used when indicated. The ESC guideline notes that a meaningful proportion of ventricular secondary mitral regurgitation can improve after optimized medical therapy or CRT, which is why reassessment before intervention is essential. The ACC and AHA valvular guideline gives TER a Class 2A recommendation for severely symptomatic primary mitral regurgitation in patients at high or prohibitive surgical risk, with favorable anatomy and life expectancy of at least 1 year. For severe secondary mitral regurgitation, American guidance supports TER in patients who remain symptomatic despite guideline-directed medical therapy, with suitable transesophageal echocardiographic anatomy, left ventricular ejection fraction between 20 and 50%, left ventricular end-systolic diameter 70 mm or less, and pulmonary artery systolic pressure 70 mm of mercury or less. The ESC and EACTS guideline is similar in principle, but adds sharper emphasis on distinguishing ventricular from atrial secondary mitral regurgitation. For ventricular secondary mitral regurgitation, TER is recommended to reduce heart failure hospitalizations and improve quality of life in symptomatic patients with persistent severe mitral regurgitation despite optimized medical therapy who meet clinical and echocardiographic criteria. These criteria include New York Heart Association Class 2 or higher, ejection fraction 20 to 50%, left ventricular end-systolic diameter 70 mm or less, systolic pulmonary artery pressure 70 mm of mercury or less, no severe right ventricular dysfunction, no advanced stage D heart failure, no coronary disease requiring revascularization, and no severe aortic or tricuspid valve disease. The procedure is performed under general anesthesia or deep sedation using continuous transesophageal echocardiography and fluoroscopy. Access is usually through the femoral vein. A guide catheter is advanced to the right atrium, and a controlled transeptal puncture is performed to enter the left atrium. The puncture must be high and posterior enough to provide working height above the mitral valve. The steerable guide and clip delivery system are then oriented above the regurgitant jet, often at the A2P2 scallops in degenerative disease, although modern systems can treat more complex anatomy in expert hands. Once aligned perpendicular to the line of cooptation, the clip arms are opened and advanced into the left ventricle. The operator retracts the system until the anterior and posterior leaflets are captured. Echocardiography confirms adequate leaflet insertion, stable grasp, residual regurgitation severity, transmitral mean gradient, and valve area. If mitral regurgitation reduction is insufficient and the gradient remains acceptable, additional clips can be implanted. The aim is a durable reduction in regurgitation while avoiding iatrogenic mitral stenosis. Significant leaflet calcification at the grasping zone, active endocarditis, thrombus, very small valve area, or an excessive baseline gradient can make TER unsuitable. Prognosis depends strongly on the cause of regurgitation, ventricular reserve, pulmonary pressures, right ventricular function, procedural success, and residual regurgitation or gradient after repair. In primary mitral regurgitation, TER can reduce symptoms and regurgitation in high-risk patients, but surgical repair remains more durable when surgery is safe and anatomy is favorable. In ventricular secondary mitral regurgitation, the outcome evidence is more nuanced. COPE showed that TER plus guideline-directed medical therapy reduced heart failure hospitalization and all-cause mortality at 2 and 5 years, while MITRA-FR did not show benefit over medical therapy. ReShape HF2 showed a 36% reduction in heart failure hospitalization or cardiovascular death at 2 years, driven mainly by fewer hospitalizations and improved quality of life. ESC trial synthesis reports reduced heart failure rehospitalization at 24 months, but no statistically significant reduction in all-cause or cardiovascular mortality at that time point across combined trial evidence. TER does not replace heart failure care. After the procedure, patients require structured follow-up with clinical assessment and echocardiography. For primary mitral regurgitation after TER, yearly follow-up is appropriate because residual regurgitation and transmitral gradients are more common than after surgical repair. For ventricular secondary mitral regurgitation, follow-up is often closer, every 3 to 6 months depending on heart failure stage, because patients remain at high event risk even after technically successful regurgitation reduction. Ongoing medical therapy optimization, volume management, rhythm care, and patient education are essential. In summary, MitraClip is not simply a device. It is a heart team strategy. The best candidates have severe symptomatic mitral regurgitation, suitable anatomy, an expected meaningful reduction in regurgitation without excessive gradient, and a clinical profile in which reducing mitral regurgitation is likely to improve symptoms, quality of life, or heart failure outcomes. Used according to contemporary AHA, ACC, and ESC guidance, mitral TER provides a less invasive option for patients who otherwise have limited therapeutic choices.